As you've heard, there is a spectrum of severity of acute graft-versus-host disease, and I think it's helpful to illustrate to you what patients go through from one end of the spectrum to almost the other. And we're going to illustrate two cases. So the first case is a patient who we're seeing as an outpatient after their initial hospitalization for transplant, and they show up with a new skin rash, and our impression is that it's acute graft-versus-host disease. They don't have any gastrointestinal involvement, and their liver tests are fine, and they're mostly feeling well, still recovering from transplant. For this patient, if the skin rash is greater than 50% of their body surface area, we might prescribe them oral steroids as an outpatient. And for the majority of these patients, we would expect that they would have a relatively good outcome. If they're young and healthy and don't have comorbidities that are affected much by the steroids, we would hope they would have a relatively uneventful course as their rash resolves and we're able to lower the steroids. However, it is a completely different journey and experience for a patient who develops severe graft-versus-host disease, most commonly characterized by lower gastrointestinal involvement. As you heard from Colleen, this is staged or measured by the volume of diarrhea they have, often exceeding 2, 3, 4, even 5 liters in a 24-hour period. This patient requires inpatient hospitalization. And Colleen has actually had the privilege of caring for patients both on the inpatient and outpatient setting and has taken care of these patients. And Colleen, would you describe what a patient who has gastrointestinal GVHD goes through?
Sure, Eben. The patient experience is a tough one, and it's very different from what you're talking about, where we can manage someone as an outpatient. With the type of gastrointestinal graft-versus-host disease that falls into the severe category, putting out a lot of diarrhea, these patients have to be hospitalized. And when we think about that hospitalization and the length of stay, we're talking about weeks to maybe a month or two. So for the patients, this is a big diagnosis. They're coming off of a long hospitalization with their transplant. When we think about the things we need to do, the first step is really diagnostically. What do we do to work this patient up? We may be suspecting that graft-versus-host disease is the cause of their diarrhea. However, these patients are also very immunocompromised. From their transplant alone, we first will rule out infections and make sure that's not a contributing factor here. We will also consult our GI colleagues for the patient to undergo a flex sigmoidoscopy for biopsies to be taken. While that's happening, we also, as you mentioned, we will typically start standard care therapy, which will be high-dose steroids for the patient. In addition, bowel rest is a big mainstay of treating this patient and helping them to recover and for the inflammation in their bowel to calm down. That means they're made NPO. They can't have anything to eat or drink, really to take anything NPO. All of their medications need to be converted from oral agents to intravenous medications. And we need to think about their nutrition. So most often, these patients are put on TPN to provide them nutrition while they're not eating and drinking. When we think about all these things, there's a lot of complications that can happen, not only from the graft-versus-host disease itself, the therapies that we're giving, the high-dose steroids. Patients deal with malnutrition, as we talked about. Their albumin is often low. They can get edema. They have issues with potential falls in the hospital, overall deconditioning. And then the whole psychosocial piece and emotional piece of what they're going through. So really, to care for these patients, it involves a multidisciplinary care team. We think about all the people that are involved to really give these patients the best care that they deserve. That involves nursing, physical therapy, social work, nutrition, all to really help the patient get through what they're dealing with in another hospitalization. It's a big journey. I think how much social work plays into the patient experience and what these patients have gone through and their families. It really is it can be a long hospitalization for them.
Thanks, Colleen. As you can see, each patient who suffers one of these admissions from this complication really hits the entire care team, and certainly the patient and the patient's family really goes through a huge ordeal here, and it really illustrates for us how much progress we have to make and why we're committed to this research. And that's why at Mass General, we oftentimes will have multiple clinical trials open to try and improve the treatment of graft-versus-host disease. And it's an interesting dynamic when a patient is diagnosed. Colleen, you see a lot of patients when they first show up in the outpatient clinic with the initial perhaps suspicion of acute graft-versus-host disease. Can you describe what happens at that point when you see that patient?
Sure, even, when we first see someone in the clinic and we're concerned about graft-versus-host disease, usually the first step is really obviously talking to the patient, evaluating the patient, and then really looking at, we think a lot about clinical trials. There's standard of therapy, but then we have so many clinical trials that are available to our patients. So it usually involves reviewing with the attending that we work with, reviewing what clinical trials are available. That also then involves the next step of contacting our research team for them to evaluate what trials this patient may be eligible for. If the patient is eligible for potential trials, that then involves talking to the patient and the family about what these trials are, what that would mean for them, explaining the rationale of the trial. And then if the patient does want to enroll in the clinical trial, enrolling them and getting that started is really kind of the big step. But involving our research team early on is really important.
We should mention that it is gratifying to see how much research is going on in acute graft-versus-host disease these days. I'll say that when I first started doing this, which was only about 12 years ago, graft-versus-host disease research was, shall we say, not very common, and it was difficult to find any trials. And these days, as you can see now when a patient presents, many centers will have multiple trials that patients are able to participate in. However, that does involve a team-based approach and time in talking to the patient and their family and explaining the rationale behind the trial. But it's only through these trials that we're able to make progress.